I'll speak today about AKI in COVID-19. What is the burden of AKI in COVID-19 infected patients? That these patients are seriously ill. The AKI here is not recognized sometimes, not coded for, did not die in hospital, and it is the eyes below, not apparent. I was honored to be one of the committee from the Egyptian Ministry of Health that have put the Egyptian guidelines for management of COVID-19 in kidney patients, and these guidelines became the African guidelines, and our guidelines in kidney transplantation became the European guidelines. What are guidelines for AKI in COVID-19 infected patients? Let's speak about the incidence of AKI to know the burden of this condition. The AKI incidence in hospitalized patients with COVID-19 infection varies from 3% up to 66%, with average about 24%. The AKI incidence in ICU patients with COVID-19 infection varies from 1% up to 56%, with an average 14%. The overall incidence of AKI-19 patients ranges from 3% up to 30%, with average about 8.9 or 9%. As you can see, the AKI incidence in admitted COVID-19 hospitals by Asian 6, of course, the more the age and the more the elderly, here we have a higher incidence of COVID-19 infection. As you can see, in ages above 85, the incidence may range from about 46% in males and 39% in females. And it is declining gradually up to from 20 to 45 years old. The incidence is declining to be 21% in males and 10% in females. The AKI incidence in admitted COVID-19 patients differs accordingly to the situation. In mechanically ventilated patients, the incidence is 74%, COPD 42%, diabetics 40%, hypertensive patients 38%, asthmatic patients 29%, with overall, of course, incidence 31%, which is a high incidence. What about the prognosis of COVID-19 severity and infection in the hospital? It differs when you have AKI. Without AKI, usually the mortality rate is 7%, while the mortality rate with AKI patients reaching up to 37%. Patients on ventilation without AKI about 5%, while with AKI is about 17%. So that AKI may worsen the prognosis and increase markedly the mortality rate. What about acute kidney injury in COVID-19 patients in different situations? In hospitalized patients, it may reach up to 15%. ICU patients, it reaches about 28.8%, and ICU with renal replacement therapy about 23%. So that with average percents 25 to 30%. Acute kidney injury occurs frequently, as we have mentioned previously, among patients with COVID-19. The overall incidence of AKI is about 37%, stage 1 47%, stage 2 22%, and stage 3 31%, with a high mortality rate, as we have mentioned previously, reaching about 35%, continuing admitting patients 39%, and only discharged may reach only about 26%. What about the percentage of patients according to the staging of AKI? Usually, when we have no AKI, usually the mortality rate is less than 3%, and the discharge rate may approaching 72%. But with stage 1, here mortality rates may approach 25% and discharge, and in stage 2 acute kidney injury, the mortality rate may reach 35%, and in stage 3, the mortality rate may approaches or exceeding 50%. So that, according to the staging of the AKI and severity of the AKI, we have a higher mortality rate, and as we can see in stage 3, discharge rate is a minority. So that mortality in AKI with COVID-19 infection. Without AKI, it is very low incidence, while with AKI, the incidence is markedly increased, reaching up to 35%, and stage 3 may exceed 50%. What about renal involvement? Without AKI, it is a minor. Without COVID-19, AKI is a minor, but when you have a COVID-19, we have a significant proteinuria, significant hematuria, significant rise of blood urea nitrogen, and significant rising of serum creatinine, and creatinine may reach its peak with stage 3 AKI and increasing acute kidney injury. What about renal involvement in COVID-19 patients is frequent and predicts mortality. The percentage of patients in hospitalized patients, usually urine abnormalities may reaches 78%, while proteinuria may reaches 65% and hematuria may reaches 40%. What about AKI incidence according to COVID-19 severity? In mild and moderate cases, only about 3 to 5% affection, but with severe COVID-19, AKI incidence may exceed 40%. And according to mortality, without COVID-19 infection, it is a low mortality rate, less than 2%, while with positive COVID-19, it is a high mortality rate. So that acute kidney injury commonly develops in patients with COVID-19, and here is the burden of the condition. About 36.6% of patients developed AKI. AKI in patients with respiratory failure may reach 90%. The high mortality rate, which approaches 35% in AKI globally, and in stage 3, it may approach 50%. So that is a great burden. What is the evidence that here COVID-19 may affect the kidney? They have detected the adhesion and facilitator genes in renal cells, and they have detected the virus in the cell, in the renal cell itself. And this is what's known as renal tropism of SARS-CoV-2. As we can see, inside the kidney, we have the SARS-CoV-2 infection, adhesion, and facilitator genes in renal cells. So that these are the ACE2, the transmembrane protein serinase, and others. So kidneys do express SARS-CoV-2 adhesion and facilitator genes, which facilitates the infection by the virus for the kidney. Here, when they have tried to detect the virus inside the kidney by PCR for COVID-19, they have detected the virus. So that in situ hybridization detects SARS-CoV-2 RNA in the kidney. And here again, they have detected in several studies the kidney, the COVID-19 or SARS-CoV-2 inside the kidney by PCR within the glomeruli and within the tubules. So that immunofluorescence confirmed that SARS-CoV-2 protein present inside the kidney. Also, we have detected primary and secondary antibodies inside the tubules of the kidney. They have detected the virus itself and the antibodies binding to them inside the glomeruli of the kidneys. So that we can here, we can say that we have renal tropism of SARS-CoV-2-19 by the presence of different genes in different situations and different loci inside the kidney, such as tubules and glomeruli, and the enrichment of SARS-CoV-2 in the glomerular compartment is very important. Is there a distinct COVID AKI? Yes. Here the receptor SARS-CoV-2 is well expressed in the kidney, particularly podocytes and renal tubules. And of course, the virus have been detected in the glomeruli and renal tubules with high incidence of proteinuria, hematuria, and other affection that we can discuss later by the presence of the PCR in the tubules and inside the glomeruli. So that the kidney is not only a presence for viral replication, but after the respiratory tract, kidneys exhibits the highest viral load. So that it is the second site for the viral load in the body after the respiratory tract. How COVID-19 pathways in the kidney can induce AKI? Through the ACE2 renal function receptor, through infiltration by inflammatory cells in the interstitium, inducing fibrosis and epithelial cells apoptosis, through activation of the complement attack unit with producing necrosis, fibrosis through hypoxia, either increase of reactive oxygen species and increase hypoxic factor with activation of cytokines, T cells, and macrophages and monocytes. And there's a crosstalk by this cytokine that it may produce lung fibrosis, and the whole result is acute kidney injury. The pathology of kidney affection in COVID-19 infection is very important. Here, as we can see, in this we have loss of the brush borders in this situation. Here we have vacuolation due to the affection of COVID-19. In this situation, we have intense infiltration by inflammatory cells in the interstitium, and here in the vessels, we have intense infiltration for the vessels by the inflammatory cells. Here also, we may have, of course, intensive infiltration of the cells, and we may have in this situation what's known as collapsing glomerulopathy, and we may have thrombotic microangiopathy with also marked thrombotic microangiopathy in the renal cells. Here, a cortical necrosis due to extensive thrombotic microangiopathy. Here we have thrombotic microangiopathy and the hairline depositions. Here we have thrombotic affecting the afferent arteriole, and in the kidney we have here the fibrin deposition of thrombotic microangiopathy inside the kidney. What about the pathophysiologic mechanisms? SARS-CoV-2 infection can, through endothelial damage, podocyte localization, proximal tubular localization, mitochondrial dysfunction, produce acute kidney injury. Through hypovolemia and prerenal can produce acute kidney injury. Through the cytokine storm with release from the monocyte, especially interleukin 6 and others, it can produce of course, the damage-associated molecular patterns, which is the danger particles released from the necrotic and died cells to produce AKI, and it can also produce endothelial dysfunction. Pneumonia itself can produce ARDS with mechanical and ventilation and ECMO with the severe inflammatory response and hypotension and renal affection. And the kidney affection may produce due to AKI, oliguria and hypervolemia, which may be injurious for the lungs. Also, the hypercoagulated state can have making myocardial dysfunction, and this myocardial dysfunction will produce low cardiac output and, of course, venous congestion due to heart failure. Also, hypercoagulability will produce endothelial damage, microthrombi, rhabdomyolysis, microembolism, kidney infarction, and the result is AKI. So that we have a multiple pathophysiologic mechanisms. Let us go more deeply what's going inside the kidney. When kidney invasion via SARS-CoV-2 entering proximal tubular cells and podocytes, it will produce acute proximal tubular injury. And of course, proximal tubular will be affected markedly. If the cells affecting the glomeruli, it may produce podocyte dysfunction and collapsing focal segment glomerulosclerosis, mesangial and proliferative lesions, and thrombotic microangiopathy, and of course, may affect the arterioles. Vascular consequences of SARS-induced coagulopathy through capillary obstruction by RBCs, coagulation activation, it will produce fibrinoid necrosis, glomerular ischemia, and of course, we have severe necrosis up to cortical necrosis in our situations. Also, cytokines storm, such as interleukin 6 and others, may produce marked injury of the glomeruli. Here, we have unspecified kidney injury factor, general factors in the ICU, from hemodynamic stability due to shock status, fluid restriction, nephrotoxic drugs, high level of PPAP ventilators, lung heart dysfunction, and its effect over the kidney. So that targeting of ACE2 by SARS-CoV-2 results in angiotensin dysregulation, innate and adaptive immune pathway activation, and the hypercoagulation to result in organ injury and acute kidney injury associated in this situation. Let us see. When the virus activates the ACE2 receptor, it may produce lymphopenia, which will increase the myeloid cell activation, the cytokine storm. Cytokine storm will produce hypercoagulability and microangiopathy, and it will produce also tubular epithelial affection and podocyte damage. While angiotensin 2 activation directly by the ACE2 receptor will activate complement activation, will reduce angiotensin 1 to 7, and this, of course, will also activate the hypercoagulability and microangiopathy, and which will lead to tubular epithelial and podocyte damage. Sepsis also here is a player. Sepsis with hypercoagulability and microangiopathy will produce acute cardiac and lung injury. Another pathway, which is direct viral invasion, will lead to tubular epithelial and podocyte damage. Also, rhabdomyolysis may occur. Here, the result is acute tubular necrosis, acute nephritis, podocytopathy, microangiopathy, and collapsing FSGS. The end results, when we have AKI and acute cardiac and lung injury, it is hypoxia and hypotension with high mortality rate. What are the mechanisms of AKI and the relation between the lung and kidney? The cytokine storm is a main relation. There is a direct, as we have discussed previously, crosstalk between lung and the kidney. And when we have ventilator-induced acute kidney injury, of course, here the mortality rate will be very high. So, mechanisms by which COVID-19 may develop AKI: prior insult, as we have discussed, tubular from ATN, cytokine storm release syndrome, ACE2 mediated, rhabdomyolysis and hemolysis related, interstitium such as were either direct nephritis or iatrogenic, vascular such as renal vein thrombosis and renal arterial embolism, glomeruli, epithelial collapsing GN, endothelial thrombotic microangiopathy, and post-renal obstruction, of course. So that here we have multifactorial elements that can produce acute kidney injury. What about the elements? Ischemic acute tubular injury is responsible for the majority, 66%, while toxic acute liver injury, 7%, ischemic toxic in this situation, 2.5%, acute kidney injury due to non-specified factors, about 13%, acute interstitial nephritis, 0.6%, de novo glomerular disease is about 2.5%, peritoneal azotemia is about 9%. So that what's going on with AKI? In our situation with AKI, it may affect the heart, it may affect the liver, it may affect the lung, and of course it will affect the brain. So that the crosstalk AKI will of course make a vicious circle and crosstalk with other organs. According to the heart, with oliguria we have salt and retention and increased preload. It will produce endothelial cell activation and increase production of inflammatory cytokines with neutrophil infiltration and myocyte apoptosis and increased inflammatory factors, with the end result myocardial damage. What about the kidney and other organs? When we have electrolytes and increase acidosis, we have a depression of the myocardium with cardiogenic shock. With oliguria, we have fluid overload, of course, with pulmonary edema. With uremic toxins, of course, we have suppression of the myocardium, and with inflammatory cytokines, here we have, of course, increased inflammation and pulmonary edema. What about the impact of the kidney on the lung? Due to non-cardiogenic pulmonary edema, the inflammatory markers will produce, of course, non-cardiogenic pulmonary edema, and increased thirst will produce, of course, non-cardiogenic pulmonary edema, and the necrotic debris and the DNA microparticles and the damage associated molecular patterns will produce severe inflammation and acute lung injury. In this situation, both cell-mediated and innate immunity may play a role. When we have activation of the T lymphocytes, it will stimulate the endothelial cells of the lung and the liver cells for caspase release, caspase 3, which will increase apoptosis and increase endothelial apoptosis and increase endothelial permeability. The increase of inflammatory cytokines such as tumor necrosis factor, interleukin 6, and toll-like receptors will stimulate neutrophils, which will invade here the capillary alveolar membrane with, of course, endothelial damage and increased endothelial permeability and non-cardiogenic pulmonary edema. What about the management? Here we have concentrate about the high-risk patients, because when they are exposed in our situation to COVID-19, the problem will be very deleterious. So that susceptible patients high risk, those are dehydrated or volume depletion, advanced age above 65, female, chronic kidney disease, plaque crisis, any chronic diseases, others, heart, lung, liver, diabetic patients, cancer, and anemia. So AKI suggested approach depends upon evaluation, detect severity and complications, start acute management, and follow-up. These are the algorithm, the Egyptian algorithm, which became the guidelines of Egypt in the management of COVID-19 and the African guidelines. If we have patients with anuria or non-oliguria, please make ultrasound, to exclude if we have a urological problem or obstructive uropathy. But in patients who are non-oliguric due to non-obstruction or oliguric, we have to evaluate volume status clinically and by other measures. If they are hypervolemic, such as heart failure, renal, or liver disease, nephrotic syndrome, we have searched for prior elements and we have managed according by IV fluids, diuretics, midodrine, glypressin, sandostatin, human albumin, vasopressors, inotropes, and others. For the high volume patients, we have start IV fluid challenge. If they are improved, they will pass in the prenal tract. If they are not improved, this means that they have intrinsic kidney disease. While if they are euvolemic, evaluate more for intrinsic kidney disease, either acute tubular injury or glomerular disease or vascular diseases such as TMA or renal, of course, and venous thrombosis, as we have discussed previously in the pathogenesis and the pathology. And renal replacement therapy may be indicated when there's indication for renal replacement therapy in acute kidney injury patients, such as, of course, hyperkalemia, intractable acidosis, intractable, of course, hypervolemia, uremic manifestations, advanced AKI stage 3, and cytokine release syndrome. This is here the algorithm for management protocol of AKI, which is we have put at the Egyptian guidelines, which have become the African guidelines for management of acute kidney injury in COVID-19 patients. We have, when patient is coming with renal impairment, detect if he has chronic kidney disease and he's stable, just conservative therapy. But if he is acute on top of chronic kidney disease, proceed in this pathway. If he has acute kidney disease, we should ask that. No, monitor the high-risk patients, as we have mentioned. All patients more than 65, chronic kidney disease, chronic heart and lung, liver disease, diabetes, cancer, sepsis, circulatory shock, and others. If here there is these high-risk patients, we should discontinue all nephrotoxic drugs, ensure volume status, ensure perfusion pressure, monitor functional hemodynamics, alternatives for radiocontrast procedures, monitor serum creatinine and urine output. But if they have AKI, we should make our diagnostic workup. If we have obstructive uropathy, consult urologist. But if there is no obstructive uropathy, and we should stage the staging of AKI. Stage 1, usually conservative therapy. If we have stage 2 and 3, according, maybe conservative therapy, maybe to continue diagnostic workup. If there is indication for ICU, will admit. If renal replacement is indicated, and the best here is to do CRRT. If unavailable, hemodiafiltration with high flux membrane. If unavailable, SLID with high flux membrane. If unavailable, SLID with low flux membrane, or acute peritoneal dialysis may be here indicated. So that here, CRRT may be needed and peritoneal dialysis may be needed. Potential mechanisms of kidney injury in this situation, according to damage and postulated mechanism of injury in COVID-19 patients. If we have cytokine damage, such as cytokine release syndrome, or increased cytokine generation, or hemophagocytic syndrome, may be due to direct cytokine lesion. Here, the management will be through cytokine removal using various approaches. Direct hemoperfusion using a neutral macroporous sorbent, plasma for adsorbent on screen, or resin after separation from whole blood. Continuous renal replacement therapy with hollow fiber filters with adsorptive properties. High dose CRRT with middle cutoff membranes or high cutoff membranes. If we have organ crosstalk, cardiomyopathy, and or viral myocarditis, cardiovascular syndrome type 1, such as left ventricular assisting device and arteriovenous ECMO. If we have alveolar damage, renal medullary hypoxia, so we can proceed for veno-venous ECMO. If we have high peak airway pressure and intra-abdominal hypertension, which means renal compartmental syndrome, we can go for veno-venous ECMO, extracorporeal carbon dioxide removal, and CRRT. If we have high peak airway pressure and intra-abdominal hypertension, the same. If we have rhabdomyolysis with tubular toxicity, CRRT with high and middle cutoff point membranes. Systemic effects, if positive fluid balance, renal compartment syndrome, continuous ultrafiltration and diuretics. If we have endothelial damage, third space fluid loss and hypotension, which may lead to renal hyperfusion, vasopressors and fluid expansion. If we have rhabdomyolysis, This may lead to tubular toxicity, and in this situation, we can use CRRT using high and middle cutoff point membranes. If we have endotoxins through the mechanism is septic AKI, endotoxin removal using polystyrene fibers functionalized with polymyxin. So that according to our postulated theory, here we can proceed for suggested management of kidney, some suggested injury of this kidney and suggested treatmentology, so that our understanding for the actual mechanism of acute kidney injury may help us in defining the proper management in this situation. Please, can I have 1 minute, please? Can I have 1 minute, please? Last slide. Please, last slide. Please, last slide. Can I have 1 minute? Can I have 1 minute, please?
Okay.
1 minute. Last slide. أنا مش عايز أقلب ليه؟ This is the last slide. Take home message. Incidence of acute kidney injury in COVID-19 hospitalized patients is about 37%. Incidence of AKI in COVID-19 ventilated patients is about 90%. The mortality rate in COVID-19 hospitalized patients with AKI is 35%. There is renal tropism of SARS-CoV-2. The receptor SARS-CoV-2 ACE2 is well expressed in the kidney. COVID-19 have been detected in the kidney, granuli and tubules. COVID-19 infection can affect the kidney by different pathologies. COVID-19 infected patients can develop AKI by several pathophysiological mechanisms. Understanding the pathophysiological mechanisms by which COVID-19 infection can affect the kidney may help in proper management. The Egyptian Ministry of Health, which I was honored to be one of their members, have implied guidelines for assessment of COVID-19 infected patients with AKI and also for transplantation and hemodialysis patients and chronic kidney disease patients. The Egyptian Ministry of Health also, which I was honored to be one of their members, we have implied guidelines for management of COVID-19 infected patients with acute kidney injury. And please stop acute kidney injury for saving life. And at the end, thank you.
Thank you, Professor Hussein, for your elegant presentation. We are all enjoyed with your updated data and the pathophysiology of AKI in the era of COVID-19.
Thank you. Thank you, Dr.
Because of short of time, we shall move to the next speaker. Thank you, Professor Hussein. See you.
Thank you. Thank you, Dr. Tariq, and thank you.